Thank you, Harsbhai, for the kind introduction. Good afternoon to all. First of all, I would like to thank APR, IMA, and ESR for giving me the opportunity, and also the physician who are coming from the outside city, and they have made this event successful. So thank you all. So we all know there is proven clinical inertia for initiating insulin from our side, and there is a fear from patient side. So insulin is not complex if we have a proper understanding. So let's simplify the insulin initiation, intensification, and de-escalation.
So good morning, everyone. So I would like to start with the one question. What came first, metformin or insulin? Yes, exactly, insulin. So before 1921, diabetes used to be the fatal disease. Then these four geniuses came together and invented insulin in Canada. And Leonard Thompson was the first patient who received the insulin. So we can see his pre-insulin picture, post-insulin picture after some time that he has gained weight and he could live till 29 years of age. Otherwise, it was a fatal disease. So he gained 13 years of life because of insulin. So this discovery changed the medicine forever. So Dr. Sagar, how would you like, when we should initiate insulin? What is the pathophysiology behind this?
So pathophysiology already has been described, but I want to highlight one point. If someone is diagnosed with diabetes, so at that time he or she had already lost more than 50% of the beta cell. So we should intervene before we are, actually it is a primordial prevention, when we should start for treating these patients. Actually this is not working, bridge. So can I get, so, oh, so please. So sorry for the disturbance. So let's begin with the indication of the insulin. So there are certain absolute indication. When we see the patient, we have to directly start the insulin, like type 1 diabetes, if there is decay, hyperosmolar state, pancreatic diabetes after pancreectomy surgery, and already discussed pregnancy with hyperglycemia on uncontrolled diet. There are, when the patient is diagnosed with the type 2 diabetes, and if there is severe hyperglycemia, like HbA1c more than 10, fasting glucose about 250, random glucose more than 300, 350, and if there is catabolic feature like patient is losing weight, there is nocturia, polyuria, increased thirst, these are the features which suggest the catabolic feature, and we have to start the insulin. And if there is a long duration of diabetes, and there is a patient is inadequate control on metformin with multiple OHS, and we have tried the GLP-1 analog and SGLT2 inhibitors, we have to initiate the insulin. So Kaushal, would you like to add few other indications apart from this?
Yes, so apart from this, we need insulin in case of any acute illness, like for example, ICU admission or perioperative glycemic management, acute coronary syndrome or stroke, steroid-induced hyperglycemia, which we are using like frequently, and CKD stage 4 and 5, and decompensated liver disease. So, and also, as Indians, we always talk that South Asians are insulin-resistant phenotype. But apart from insulin resistance, we are also insulin deficient phenotype. So we have a dual defect actually, insulin resistance as well as impaired beta cell function. So we need insulin early in the course of diabetes because we have a lower reserve inherently. So that's why our patients need insulin sooner and more frequently. So Sagar, just throw some light on what are the types of insulin available out there.
So definitely, based on the onset of action and duration of action, insulin are classified into ultra rapid acting insulin, rapid acting insulin, short acting, intermediate acting insulin, and long acting and ultra long acting insulin. So I will just give the name. Pharmacokinetic property will be discussed in subsequent cases. So ultra rapid acting insulin includes the fast acting aspart like Fias and fast acting Lispro Lumjev. Rapid-acting insulin includes the Epidra, Humalog, and Norepid. Short-acting, as we are using regular insulin, and intermediate-acting insulin and NPH. long-acting insulin like glargine and detimir, and ultra-long-acting insulin U300 glargine and degludec insulin. We are all using premix insulin. There are human premix like 30, 70, 50, 50, and there is premix analog like Aspart and NPH 3070 and Lispro and NPH combination 2575. And we have a newer co-formulation like insulin degludec and Aspart combination 3070, which is actually we don't have to mix, it is equally distributed, the molecules are evenly, co-formulation is there, we don't have to mix this insulin before the injecting. So let's begin with the case 1, 56-year female, Mrs. X, type 2 diabetic, 25 BMI, duration of 17 years. There is a recent history of weight loss for 3 kg and nocturia, and her current medicine is metformin full dose glimepiride 4 mg. There is combination of linagliptin and empagliflozin, and she is taking acarbose 50 mg 3 times a day. Despite this, her HbA1c is 8.3, fasting 178, and postprandial glucose is 210. So, Kaushal, how will you approach this case?
Yes, Sagar. So let us see step by step. So first of all, duration of diabetes. It is 17 years. So 17 years is a long time to have a beta cell failure. So she might be going now in the beta cell failure. The second is osmotic symptoms. She is losing weight, she is having nocturia. So that is a sign of relative insulin deficiency. The third one is patient is already on the significant doses of oral hypoglycemic agent. So now there is not much room to add other OHA to get her glycemia under control. And fourth thing, delta gap between the fasting and PP sugar. Here it is only 32. So predominantly there is a fasting hyperglycemia. PP is not very high as of now. So in these cases, I would like to start with a basal insulin and reduce the dose of glimepiride by 25 to 50%. So what are the basal insulins available as discussed? Glargine, U300, that is nothing but the concentrated glargine, and degludec. Now, degludec is the smoothest insulin. It has a half-life of 42 hours, and it has a lesser risk of nocturnal hypoglycemia. So, given the choice, I would prefer degludec, but if there is a cost issue, then we can move to glargine or U300. U300 can be used in a situation where we require very high dose of insulin, like glargine more than 40 unit, 50 unit, because it is sometimes very painful for the patient to take such high dose because of the high volume. In such scenario, we can use the U300 as well. So, but because of cost constraints, he was started on the glargine 12 units, and then initially, then it was increased gradually. So, how we initiate? Initiation is 0.1 unit per kg or 10 units, or sometimes depending on the fasting sugar. If fasting is 300 or 350, then 10 units will not work. In such patients, we can directly start from 14 or 16 unit. We have to monitor fasting glucose every third day. We increase the dose by 2 to 4 units. And we need to see that if there is no hypoglycemia, especially at the night. Now, the patient was well maintained for next 3 years, but after 3 years, she came with a uncontrolled diabetes. That is, HbA1c was 8.6%. She was taking already 22 units of glargine with all other OHA. So, to know the cause, I advised the CGM. CGM was showing this picture. So, Sagar, how would you like approach this case further?
So let's first analyze the CGM profile. So here the fasting is very well controlled between 80 to 130. There is no nocturnal hypoglycemia, no over-basalization as the dose was only 22 units. But we can see here the post-dinner glycemic excursion. So in my opinion, to counter this, we should use basal plus regimen. We all are using basal insulin. We all are using premix insulin. But there is in between one more regimen we can use. Here only the issue is post-dinner. Post-lunch is still very well controlled. So to tackle this post-dinner hyperglycemia, I would like to add one bolus insulin that will create one basal and one bolus dose, that is basal plus regimen. So we have all three options like short-acting insulin, ultra-rapid-acting insulin, and rapid-acting insulin. We all know the advantage of the analog insulin. It matches its pharmacokinetic property, matches with the post-glycemic excursion, and it has a very rapid onset of action and short duration of action, so very less chances of hypoglycemia and better glycemic control we can achieve. If there is no financial constraint, we should use analog insulin. And if there is financial constraint, I would like to add a regular insulin to this case. So how should we initiate? There are three strategies. We can directly start with the 4 unit pre-dinner, or we can use a 0.1 unit per kg per 0.1 unit per kg before dinner, or we can use a 10% of the basal dose in this case. We should monitor post-dinner 2 hour, we should target below 180, and simultaneously we should monitor fasting also, because once the post-dinner is reduced, there may be chances we need to reduce the dose of basal insulin also, and we should monitor every 3 to 4th day the SMBG profile. So
Sagar, I have another case for you as well. So this is a 59-year-old male here, type 2 diabetic since 14 years, weight 70 kg and BMI of 26 kg per meter square. Presented with weakness, typically thinning of limbs and weight loss of 3 kg. He is also on significant OHA doses, metformin 1000 mg and glimepiride 2 mg twice a day, dapagliflozin, sitagliptin 100 mg, glargine 30 units already. So on this regimen also, his FBS is 180, PP sugar is 334, and HbA1c is 9.8. So now, how would you approach? Because he's already on the basal insulin. So how would you approach this case?
So I can say this is garden variety of case which we are all seeing in our OPD. So let's first analyze this case. Long duration of diabetes, type 2 beta cell failure is there. Very high HbA1c, uncontrolled sugar. There is fasting is also high, postprandial is also high. There is a catabolic feature like weight loss, which is due to relative insulin deficiency and uncontrolled sugar. He is already on basal insulin, inadequate control, and we need a both coverage, like basal coverage to normalize the fasting, and we need to control the postprandial. So we will use to here premix insulin, because it's simple, very easy to initiate, and only 2 injection, faster correction of fasting and postprandial glycemia. So here I would like to use a premix insulin. The options we have already discussed, but how to initiate? So to initiate, we can initiate like 0.3 to 0.5 unit per kg per day. So 2/3 in the morning and 1/3 in the evening. So we need to monitor the fasting for evening dose adjustment, and we need to assess pre-dinner to decide the morning dose. And simultaneously, we should check the postprandial sugar in between to prevent the nocturnal hypoglycemia. So I would like to initiate the premix insulin. I will titrate the dose by 2 to 3 units every 2 to 3 days, depending upon the patient profile and insulin resistance. So this patient was following with me for next 4 years. He was maintaining HbA1c between 6.5 to 7%. But at present, despite consistent medical nutrition therapy, exercise, and all the medical therapies, he was not maintaining the HbA1c. So I decided to use a CGM profile. So this is CGM profile. So Kaushal, how would you like to approach this case?
Yes, Sagar. So I think we have used our almost all the weapons. So now the king has to come, king of the regimen has to come in the picture. First, let's analyze the case. Uncontrolled glycemia on premix insulin. CGM was showing haywire pattern, large intraday variability, because we could see the gap was very high between the two lines. Post-meal spikes on different meals on different days. So there is no pattern, it is a very random. So definitely he needs a customized dose for each meal. Premix cannot give customized dose for each meal. So, and he is also having simultaneously hypoglycemia also and hyperglycemia also. So to mitigate all this, we need most suitable regimen for such patient is a basal bolus regimen, right? Because here we will get flexibility of 3 pre-meal dose and 1 basal dose for the fasting sugar. So how to shift such patient from premix to basal bolus? So here in bolus, we use 3 to 4 times short acting, because sometimes many patients have a habit of evening snacking at 4 p.m. or 5 p.m. So they may also require short-acting dose at that time also, otherwise they will have a pre-dinner hyperglycemia, which will be difficult to control. So short-acting 3 to 4 times plus 1 long-acting. Guideline says 50% basal, 50% bolus, but it does not work in Indian scenario because we have a very high-carb diet. So we usually start with 30% basal and 70% bolus. Monitoring 6 times SMBG initially to decide all 4 doses separately. And titration is based on the fasting glucose, we titrate the basal insulin, and each respective post-meal glucose, we titrate the respective bolus doses.
So, Kaushal, before going to next slide, I would ask you two questions. How would you prefer regular human insulin versus analog insulin? What is your preference? And second question, when we are using basal bolus insulin, so how important it to emphasize on insulin technique and rotation of insulin injection site? Would you highlight about this?
Very great question, Sagar. So yes, this is the human versus analog, very common issue. So human insulin is definitely affordable, but it is having a slow onset of action, and it does not match usually our glycemic pattern postprandial. So it will have a little post-meal hyperglycemia and next pre-meal hypoglycemia. While the analog is little costlier, but it usually matches very well our glycemic pattern after meal. So it is having less risk of glycemia and also having the better sugar control. So if affordability is not the issue, definitely go for the analog insulin. Otherwise, we can also use the human insulin. Also, coming to your second question, that technique importance, that I would like to highlight with a simple case. She is a 40-year-old female, uncontrolled sugar. She is only 60 kg weighing, but she is already on premix 48 twice a day, that is 96 unit. Also plus glargine 30 units, so almost 130 units for a 60 kg lady, so more than 2 units per kg. She is receiving, and despite this, sugar is not controlled. So like we have asked her regarding insulin type, she is using correctly, insulin storage is correct. So now what is the next step, right? So once we examined her insulin site, insulin injection site, it showed gross lipohypertrophy. So whatever insulin she was taking, actually it was not delivered to her blood. So this is a very important to emphasize the patient that site rotation, needle frequency change, and to examine the insulin site on every visit they come to us. So this is a typical case of lipohypertrophy. And Sagar,
So
would you like
I
to?
would like to highlight, we are using premix insulin so commonly. So this is a 43-year-old male auto rickshaw driver, type 2 diabetes, 13 years, OHA with insulin. He presented with severe hypoglycemia, 25 sugar. So what is the error over here? I want answer from you. So what is, yes, so we all know, okay, this is available in 10 ml mixed start vial. It's 100 unit per ml. If we are using 100 IU per ml, we need to use a 100 IU syringe, which is orange color. So we definitely need to take this consideration. So, Dr. Kaushal, we all know patient question પૂછે કે સાહેબ ઇન્સ્યુલિન ચાલુ કર્યું કેટલા ટાઈમ લેવાનું, લાઈફ ટાઈમ લેવાનું, ક્યારે ઓછું કરવાનું. So, Kaushal, would you highlight about this thing?
Yes, so there are definitely, of course, obvious situations like recurrent hypoglycemia or HbA1c is like below the target. In such issue, we have to de-escalate. We may change the reg, we may change from basal bolus to basal plus regimen. And nowadays, we are adding GLP-1 RA. So that time also we need to reduce the basal by 20% and bolus by 25 to 50% to avoid the hypoglycemia. Apart from this, if there is an elderly individual who has a limited life expectancy, then we should give them complex regimen rather than, because there is no risk of diabetic complications like other patients. So that also should be considered for the de-escalation. Also, I want to highlight reversal of glucotoxicity. We seldom start, like for example, 40-year-old newly diagnosed type 2 diabetic come to us obese, HbA1c is 12. And we even do not offer them insulin at first visit because we know that they will not take it. But if we give them insulin and if they take it, there is a high chances of remission of diabetes at 1 year. This is a very old 2008 Lancet study. That if they choose insulin, if they take only for 1 to 2 months, it will give them beta cell rest. And there is a high chance of diabetes remission. Now, Sagar, most feared complication of insulin is hypoglycemia.
Definitely. The most feared complication is hypoglycemia. We all know about autonomic and neuroglycopenic symptoms of hypoglycemia. I would like to highlight one case, 21-year-old male type 1 diabetes for 16-year on basal bolus insulin, poor glycemic control, having all the microvascular complication, and recurrent level 3 hypoglycemia. So this is a hypoglycemia unawareness, which usually happens in two situations, like if we have a tightly controlled, antecedent tightly controlled glycemic, like HbA1c is 6.3, 6.4, or in this case there will be hypoglycemia unawareness, and in case of autonomic neuropathy there will be hypoglycemia unawareness. This is very risky situation, 25-fold risk of hypoglycemia and very high risk of cardiac arrhythmia and sudden death. So we need to take this into consideration.
So now we have certain spotters for you. So we want answer from you, like in 10 seconds. So what is the relevance of NPH? It is relevant today, or we are not using it at all? Anyone? So yes, there are very few situations where NPH is still relevant. It is steroid-induced hyperglycemia because it matches the pattern of the prednisolone. So once that will be effectively control the glycemia who is on steroid. Pregnancy also we can use, but we are not using practically right now.
So second spotter, we usually see the site of insulin injection over the calf. So is it really site of insulin injection, and what is the diagnosis? We have seen n number of patients in our OPD, those who are injecting injection on the calves. So this is a lipohypertrophy, and this is not an ideal site to give an injection. We should avoid using insulin on calf.
So we can see the coarse face, the prominent veins of the hand, loss of fat, hypertrophied calf. So she is the case of lipodystrophy, right? So what is the relevance to insulin here? I just wanted to highlight that this kind of patients require a very high dose of insulin, even 100, 200 units of insulin per day, right?
So for again revision, what is the error over here? So again, take home message from our side, don't use 40 IU syringe in 100 IU insulin.
So is there any rationale for using this combination, glargine plus premix? Right.
But we are seeing so many prescription with this premix insulin and glargine. We are over-basalizing in this situation, and there is huge risk of midnight hypoglycemia if we are using this insulin regimen simultaneously. And last, I think.
Yes.
So, yes, this is the last question. Is there any rationale of premix insulin in type 1 and pregnancy? I am not hearing loud answer, so we definitely need answer for this question. No, big no.
Big no, right. So last question now. We have all read Somogy effect, especially in the MCQs. We always remember that this MCQ will come, Somogy effect, as a cause of fasting hyperglycemia. But is it real? How many patients we discover in the practice? Right. So exactly, it is a very rare phenomenon, and right now it is actually theoretical phenomena. So more common is the dawn phenomena. Dawn phenomena is where there is a rise of sugar after 4 a.m. due to rise of early morning hormone surge like cortisol. In Somogy effect, what is the purpose is there is a nighttime hypoglycemia, and then there is a rebound hormone rise, and there is a hyperglycemia. And if our dose is insufficient, then the sugar will be continuously high overnight. So dawn phenomena is much more common. Somogy effect is actually not very relevant in our practice. So with that.
So we have concluded this session. In conclusion, I would say overcome inertia, simplify the insulin, and relieve the fear of patient and improve the standard of care. Thank you so much.
Thank you.